Hello.
Waalaikumsalam, Doctor. We don't have class at
You don't have. So you are available lah at 12.
yeah.
All of you lah, 42. Why not we just combine? We just complete for this session for today. Can we just because tomorrow we have another 1 hour. Can we just combine until one or until just complete all the presentation today? Or do you have any other things to do?
No, Doctor, but there is a smaller group that will have LCT class with Dr. Abu at 2.
Oh, at 2. At
Yeah.
2, right? Kalau macam kita okay, it's okay lah. We do at 11 until 12. Because you want to prepare for your next class, right?
Yes, Doctor.
Okay. We start with our first presentation today.
Okay, Doctor. So I'll start now.
Okay.
So good morning to Doctor everyone. So today I'll be sharing on nasogastric tube. So this will basically be what I will cover. So nasogastric tube is the plastic tubing device that will allow delivery of the nutritionally complete feed directly into the stomach or removal of the stomach content. It is passed via the nose into the oropharynx and the upper GI tract. So nasogastric tube is from the oropharynx down to the GI tract, right? So for patients who cannot, there's other methods that is directly into the duodenum or to the jejunum. So this is the parts of the nasogastric tube. So we have the from the tip to the lateral eye, there's a radial opaque line. That's the color code for the different sizes. The length marking. So for the indications and contraindications, for the indications, so mainly it's for feeding purposes, medication delivery, removal of gastric contents, and also for diagnostic uses. So for feeding purposes, it's mainly for malnourished or people who are at risk of malnutrition, and they must have inadequate or unsafe oral intake with a functional, accessible gastrointestinal tract. So occasionally, it's also used to prepare malnourished patients for major abdominal surgery in the preoperative period. So generally, nasogastric tube is only advised for up to 4 weeks. After that, we should start oral feeding or percutaneous endoscopic gastrostomy, which is a more long-term measure. For removal of gastric contents, it can be used for initial and continued gastric decompression in the endotracheal intubated patients, for symptom relief and bowel rest and bowel obstruction, aspirating ingested toxic material, and also for diagnostic users to assess presence of volume or upper GI bleed, and also for administration of radiographic contrast. And for the contraindications for nasogastric tube, there are absolute contraindications and relative contraindications. For relative contraindications includes like coagulation abnormalities, recent alkaline ingestion, esophageal varices, and also esophageal strictures. So for relative contraindications, we have to weigh the benefits and the risks and then decide upon that. So for complications include incorrect placement leading to aspiration, discomfort, gagging or vomiting, tissue trauma, esophageal perforation, which is rare, and others include abdominal cramping, swelling, diarrhea, regurgitation of the food or medication, tube obstruction, tube perforation, and tear. And it's for long-term use. We can also lead to sinusitis, infections, ulcerations of the tissue of the sinus, throat, esophagus, or stomach. So for the procedure, first we need to know what's the equipment. So of course it will involve a nasogastric tube, a dressing, disposable gloves, lubricant, disposable bowl for the vomiters if the patient is vomiting, paper towels, large syringe, pH testing strips. Optionally, we can prepare a glass of water with straw, local anesthetic spray, and also suction tubing and container. So for the preparation, we have to gather the equipment, prepare it beside, and then introduce ourselves, explain the procedure on the indications, complications, and also what we'll be doing, gain consent, and we'll ask patient for any pain, any allergies, especially to latex, any recent nosebleed. If no, we can position the patient either in sitting straight upright or in the high phallus position. And then we'll wash our hands, we'll check for any septal deviation. If no, we can measure the nasogastric tube. We'll measure at the bridge of the nose to the earlobe and then down to 5 cm below the surface sternum. After that, we can note the length. Usually it will be around 50 centimeters. Then we'll apply the local anesthetic spray to the back of the patient's throat for comfort. This is optional, but if we were to apply, we have to wait 5 minutes before inserting the nasogastric tube. So we'll lubricate the tip of the nasogastric tube either with lubricant or with sterile water. Then we'll warn the patient that we're about to insert the nasogastric tube. Then we'll insert through one of the patient's nostrils. We can ask which nostril patient prefer. And then it should be inserted at an angle parallel to the nasopharynx floor. Then we'll gently and slowly advance the nasogastric tube through the nasopharynx. So once the resistance is met, we can rotate the nasogastric tube to aid insertion. We can also ask the patient to flex their neck. This is to close the trachea and to open the esophagus. And then we should avoid forcing the nasogastric tube if there is significant resistance encountered. If the patient becomes respiratory distressed, we can pause to give some time to recover. So intermittently, we should inspect the patient's mouth to ensure the nasogastric tube isn't coiling. Then we should continue to advance the nasogastric tube down the esophagus. And again, ask the patient to drink and swallow some water and advance while the patient is swallowing. This will facilitate the advancement of the nasogastric tube. So once we reach the desired nasogastric tube insertion length, we will fix the nasogastric tube to the nose of the dressing. So before removing the guided wire, we should assess for the placement first. So methods that should never be used to confirm the placement is the auscultation of air insufflated through the feeding tube. This one is usually used as a bedside test. It can help to determine, but it cannot be used as a single confirmatory test because it is not as reliable. So what we can do is we put the stethoscope at the epigastric region, and then we use the syringe and pump in some air through the tube. And if we can hear sounds, it means that it's in the gastric region. But this one is not reliable as a single test because we can mistaken bowel sounds or chest sounds as the correct placement. We should also not test the aspirate by using the blue litmus paper because the blue litmus paper can turn pink even at the pH of 6 and 7, which we cannot distinguish whether it's a bronchial aspirate or a gastric aspirate. And then we should also interpret, we can now interpret the absence of respiratory distress as an indicator or monitor bubbling at the end of the tube. Because both of this is to actually, it can be a false result if the tube is occluded by the pulmonary tissues. So monitoring bubbling can be done like if you take a galley pot and you put water and then you put the tubing to see if there's any bubbles. Observing the appearance of nasogastric tube aspirate, it cannot be a confirmatory test because sometimes you cannot aspirate fully. So for the correct method, you can either confirm by measurement of the nasogastric aspirate pH using the pH indicator paper. The safe range will be around 0 to 5.5. Or otherwise, we can check using a chest X-ray. For patients who are on proton pump inhibitor, we should confirm using a chest X-ray, or for those who have undergone any gastric surgery. Because for patients on proton pump inhibitor, it can alter the gastric pH. So for checking on chest X-ray, first we need to ensure that the radiograph is straight. There's adequate view exposing the esophagus down to the diaphragm. If yes, then we can identify the carina if the tube passed down the midline, bisecting the confluence of the left and right bronchi. If yes, then we can see if it passes down midline past the diaphragm and deviate to which side. If it's the left side and we can see the tip, means it's suddenly in the stomach. If no, we can see the CM marking at the nose tip where we measured just now earlier on. If it is at the correct line, means that it is in the stomach. Okay, so we can look at the correct one. So here we can see that the chest ray field of view is adequate. The nasogastric tube bisects the carina. It remains midline down to the level of the diaphragm, and the tip of the nasogastric tube is clearly visible and below the left hemidiaphragm, and is 10 cm beyond the gastroesophageal junction, and therefore is likely to be within the stomach. So for example here, the figure 2, the nasogastric tube is actually caught in the tracheal or brachial tree, and for this it is in, for the figure 3 is in the lower lobe of the right lung with infiltrates, and for the last one is inadequate insertion leg. So for the last one, even though it's in the stomach, but most likely when we do nasogastric feeding, it might still end up in the esophagus, so which will lead to reflux of the food or the medication and lead to aspiration. Therefore, in this case, we also need to insert further and take another chest X-ray to confirm later. So lastly, once we've confirmed that it's in the correct placement, we can remove the guide wire, clamp the ends or attach it to the drainage bag or suction, explain to the patient that the procedure is now complete, and then reassure them that they will become comfortable over hours. Thank the patient, offer them paper towels to clean, and then dispose of used equipment, wash our hands, and also document the details of the procedure. So that is all for my part.
Okay, this is a simple procedure, I think, nasogastric insertion, but you have to try yourself to get your experience how to insert the rice tube. The most important thing is you have to confirm the position of the nasogastric tube. Your next slide. No, usually kan in the ward, usually we just using our stethoscope and shrink. But the most important thing, just like you mentioned just now, we have to confirm the aspirate pH using pH indicator paper, and then you can do your chest X-ray and others lah, supporting the rice tube position confirmation. Right? Have you get the experience to insert the rice tube before?
Not on a real patient.
Not on the patient. Sometimes we really need cooperation from the patient. You have to ask them to swallow. Sometimes it will stuck in our throat. That's why we have to ask patient to swallow. Okay, next topic. Can we move on?
Yes, doctor.
Yes, Doctor. And the next topic will be presented by me. Allow me to prepare myself for a moment.
Okay.
Okay, so can you guys see my slide?
Can you make it bigger? Yes.
Okay.
Yes.
Yeah. Thank you.
Okay. So, Assalamualaikum and a very good morning, good afternoon, everyone. So, I will be presenting about the Glasgow Coma Scale. Very brief. So if there's any question that you guys would like to ask later on, please do so. So a little bit of history on the Glasgow Coma Scale is where the name of Glasgow comes from is from the Glasgow University themselves. So it is created during the 1974 by two university neurosurgery professor, Graham T. Steele and also Brian Jennett. So these two professors created this Glasgow Coma Scale to help us assess patient who have reduced in consciousness or presented with loss of consciousness. So they also have their own university website where you guys can learn more about this Glasgow Coma Scale. I have included the link in my last slide, so you guys can refer later on. So, what is Glasgow Coma Scale? It is a clinical assessment that describes the extent of impaired consciousness of the patient in any types of acute medical cases and also traumatic cases. Um, Primarily, it is commonly used in context of head trauma, but it is also useful for us to use in non-trauma cases, such as if the patient does not have any head injury but also presented with reduced in consciousness. We can also use this Glasgow Coma Scale to help us assess the patient conscious level. So yeah, one of the presenting complaint, patient will be presented with loss of consciousness itself, or also reduced in conscious. Um, and how we assess this GCS is by these three aspects. You guys can remember it by remember it the beginning of the words EVM, which is the eye-opening response, verbal response, and also the motor response. So this each assessment have their own respective scoring component. So for I, there's only 4. Verbal, there's only 5. And motor, there's 6 of them. And then how we elicit the score is by getting the highest, by scoring based on the highest response given by the patient, which I will further elaborate more in my next slide. And to assess this patient severity is by adding up all the score we given towards the patient. So it is a cumulative sum of all score, and it will give out a total of 15. The lowest score is 3. There is no 0 scoring. And then we can classify the severity based on the mild, moderate, and severe score, which I have listed here. So the way we document GCS score is by putting out GCS and then the total number of scoring, and then we single it out into each component, how much they score for the eye opening response, for the verbal, and then for the motor response. Okay, so these are where can you find the Glasgow Coma Scale chart is in the primary assessment of the patient. So this is an example for the adult head chart from our own hospital, and this one is from the I got it from the CPG of head injury in adults. It's just the same component. So the Glasgow Coma Scale located with it is the first component in this chart, the response level. You can see that there is eyes, verbal, and also the motor response. This is how the patient responds to our commands, and then this is the scoring. And other things is how we document it is by I'm not sure how to zoom the picture, but you guys have the slide, right? So probably you guys can zoom it. Sorry. And have the patient's name, patient identification number, and also the patient's age. Other assessment, I would not elaborate on it because I will only focus on GCS. Okay, so the first component of GCS scoring is the eye-opening response. So we have 4 score. First, spontaneous, to speech, to pain, none, or non-testable. So how do we assess a patient is we have to be vigilant towards patient when assessing the patient. So if we are coming to the patient, we are going to the bedside of patient, and we see that patient is in normal condition, they can open their eyes, they are sitting properly. So that is spontaneous, which is that is all, and there it is for eye opening response. So it is the easiest way to assess it. However, if you come in to the bedside and patient is not opening their eyes, so we have to speak to the patient, like asking them if they are okay, and if only with our voice. And if the patient respond by opening their eye towards our voice, so that is 3 points. And however, if patient still doesn't respond to our sound, we have to apply pain stimulus towards the patient. So there are 3 ways for us to apply stimulus to the patient, pain stimulus to the patient. First is by applying the pressure towards the fingertips. Second is by squeezing the trapezius muscle. Third is by applying pressure to the supraorbital notch. So you can do it these 3 ways, but normally we assess it by applying pressure to the fingertips because that is the most not so painful way to assess the patient. So how we do it is by taking a pen or any blunt instrument, and then we press it on the nail bed of the patient. So we do that for about 10 seconds. By applying pressure, remember that it should not be soft. But however, we must not apply too much pain towards the patient. Just adequate amount of pressure is sufficient. And then, if patient are able to respond by opening their eyes, this pain stimulus, then we give them score as 2. However, if patient still does not give any response, they don't open their eyes, so there is none. We score it as 1. And have to remember that if the patient have periorbital edema or any difficulties to open the eyes, like they have dressing over the eyes, like wearing an eye patch, or um, have dressing edema or any trauma on the eyes, so we cannot score them as 0, but we have to put it as not testable. So can put it as NT or TDD. TDD means tidak dapat diuji. So that's for eye opening response. Okay, for the next component is the verbal response. So verbal response is we are trying to engage the patient in a conversation, and we are assessing if they are orientated to their surrounding. So if you guys remember the mnemonic PPT, person, place, and time. So we are assessing patient by asking question about like asking about the names, where are they at the moment, and then if they know about the date or month that of that day. So when we ask that question and patient are able to answer appropriately by saying the name, for example, like they answer Hashim, I am at in the ward, and this is we are in June. So we can score them as 5 points, meaning that they are able to answer appropriately. But however, if they took some time to answer it and they look like they are thinking, they are finding the answer, meaning that the patient is confused. So that is 4 points. But for words, patient will respond with random words. Most oftenly, patient can swear, and they will give out gibberish words, which is not related to the question given. So we can score them as 3. However, if patient only groans, give out sounds, there is no audible words heard, so we can score them as 2. But if they are unable to give any response to the question, so we score it as 1, which is none. if the patient are intubated or they are mute, any factors that are interfering their ability to speak, so we count it as not testable. Okay, so that's all for verbal response. Moving on to the motor response. So this one, we are assessing the patient's muscle. This is completely different from the neurological examination we did in short case. So this one, we have the first thing first, we have to perform two-step action, meaning that we are testing the peripheral stimulus by giving commands such as we are asking them to lift your arm off the bed. That is the first request. And then the second request is by asking them to make a fist. Or you can also ask the patient to put their tongue out and then put their tongue in. Any comment that requires to request action. So if they are able to do that, so we give it as 6 point. And just now we are assessing the peripheral stimulus. Now we if by assessing the peripheral stimulus it is not adequate, we have also to assess the central stimulus. So how central stimulus is assessed is by applying pain, by giving pain stimulus towards the patient. So similar methods that can be done for motor response, except that we do not apply pressure towards the nail bed because we are going to observe the motor, right? So if so applying pressure to the nail bed will restrict the movement. So what we can do is by squeezing the trapezius muscle, or also can apply pressure to the supraorbital notch. And when applying the pain stimulus to the patient, if the patient are flexing their hands and trying to reach towards the side of the pain, meaning that the patient is localizing the pain. So we score it as 5. It is different with normal flexor. Normal flexor is when patient only responds to the pain um, by flexing their arm. They don't bring their arm towards the stimulus. If you guys are understanding it. So that's how we differentiate the localized pain and also the normal flexor. So before I further elaborate more on the abnormal flexor and extension, if patients are unable to give any response towards the stimulus given, so we score it as 1. But if the patient is paralyzed, non-paralysis, or if he has if the hands are in crutches or any factors that limits their movement, so we count it as not testable. Okay, so for abnormal flexor, when we apply pain to the patient will flex their elbow and then they will cross their arms to the center, to our body. So this is the abnormal flexor, the normal position in abnormal flexor. So the arm will be abducted, internal rotation of the shoulder, there will be elbow flexion, pronation of the forearm, and then also the wrist flexion. For extension, the patient will be in rigid position. The arm and legs will be extended and internally rotated. His teeth will also be clenched, meaning that they are unable to move their body to remove the pain. So that is how you are going to score for abnormal flexor and also extension. Okay, so I put like an example of GCS score that I got here from the ward. You guys can have a practice on it later on because it's hard to see the picture in the slide, right? So I think one of it that we can practice is how to perform the GCS assessment and how we are going to document the GCS scoring based on the charts here. If you can see that there is a date noted here, and then they do it the time they document the time that they do the GCS assessment, and then they will put a dot at the score that they give towards the patient. And then these are the total sum for the scoring of all of it. I think that's all for GCS. These are the references that you guys can look later on. These are the website that I mentioned just now. Any questions?
Okay, thank you, Isha. Any questions?
Doctor, yes. Can you hear me, doctor?
Hello?
Doctor, my question is how frequent do we do the Glasgow Coma Scale assessment for a
How
patient?
how frequent? Basically, once we see the patient, especially in patient presented with loss of consciousness, we have our first when we first attending the patient, of course we have to do our vital sign and also GCS. And then let's say patient the GCS let's say it's patient 14. The four component the second component is only confused on 14 over 15. And then basically we have to monitor every time we see this patient lah. But let's say if patient in GCS because our indication for intubation one more is GCS 8 and below. That one we have to monitor frequently. Basically, it's already it's just like your no vital sign. When we see the patient, you automatic you have to know what's the GCS. It's not like for hourly. We can do sometimes for hourly GCS. But let's say if the GCS keep dropping, you have to monitor frequently compared to patient with on GCS 14 only lack of 14 is lacking only a confusion. Right, that one you can monitor every review, okay. But if the GCS coming down, you have to monitor very frequently. There is no guideline, no specific guideline. You have to how frequent you have to monitor, but because the patient condition is very flexible. Sometimes you see this morning patient DCS is full, but suddenly 10 a.m. suddenly patient DCS drop to 3, 4. We cannot expect and the thing can happen lah. That's why we have to monitor our patient closely. Even patient who just walking around you, who just walking in front of you, and then 1 hour after you saw a patient, the GCS drop to 4 and then require intubation. So that once you come into to ward, the most important thing apart from your vital sign and the GCS, you have to acknowledge either you have to know how to differentiate. Is it how patient looks like confused, aphasia, and then either sometimes we can sometimes if we're not very familiarized with GCS, sometimes you thought patient is sleeping. As actually the GCS already dropped. That's why we require urgent intervention. Okay, is it answering your question?
Yes, doctor. Thank you, doctor.
Especially that's why once you come into ward, you have to sometimes you have to remember yourself and the GCS, the score, how to give the score. Sometimes it should be your reflex lah. Okay, can we move on to your next topic?
Doctor, sorry, I have one question.
Mm-mm.
I want to
Okay.
clarify. So, for the motor response, I read that for if the patient are able to obey commands, so we give it as 6. But we also have to assess the patient central stimulus as well, right? So do we also have to assess by like giving the pain stimulus to the patient, or by the patient obeying command is sufficient?
This one by obeying command is already sufficient.
Sufficient.
We
Okay.
just yeah, he can obey command. Of course, that's 6. Localized pain is actually like this: when you apply the pain, and then patient the hand moving towards the pain. But sometimes in what patient that not really obey command, but still moving all the 4 limbs, you can give the score 5. Sometimes kan you have patient that not obey your command but still moving all 4 limbs, not only flexion or not only extension or flexion but still can move it around. We can give a score of 5 for motor. But if he is obey the command, you can put 6 lah.
Okay,
Okay,
thank you, doctor.
we can move on to next.
Okay, I'm Aisha and I will be presenting for the next topic, which is urinalysis.
It's just a simple, right? This one.
Yes. Can you guys see the screen and hear my voice clearly?
Yes.
Yes.
Okay. Okay, so this is the content. So urinalysis is basically it's a diagnostic tool that we can use to examine the visual, the chemical, and the microscopic properties of the urine. So we can monitor and diagnose medical conditions, including kidney disorders, for example, urinary tract infections, or systemic disease such as diabetes mellitus. So these are the equipments that you need to do the urinalysis: the hand wash or hand sanitizer, glove, apron, urine lipstick, urine sample, and paper towel. Okay, so before we do the procedure itself, we have to assess the urine. So of course we have to wash our hands and then confirm the patient's detail, whether it's correct or not. We don't want to mistake it for another patient. So we have to check the name, the date of birth, and the hospital number. So first of all, what we want to assess is the color of the urine. So we have the straw color, which is normal, and this is in a healthy, hydrated individual. For the dark concentrated urine, this suggests that the individual may be dehydrated. For the red urine, self-explainable, there will be presence of blood in the urine. Porphyria, this is a condition, is a rare hereditary condition where there is an abnormal metabolism of hemoglobin. So porphyrins are excreted in the urine. And then drugs such as rifampicin and certain food like beetroot can also cause red urine. So the last is the brown urine. So we can see presence of bile pigments or myoglobin in the urine, and some anti-malarial medications such as chloroquine can also cause brown urine. Apart from inspecting the color, we have to also inspect the clarity of the urine. So we want to see if the urine is clear. In this case, clear urine is normal. If it's cloudy with sediment, it may indicate urinary tract infection, renal stone, or high protein content, like in nephrotic syndrome. And if the urine is frothy, it is associated with significant proteinuria, such as in nephrotic syndrome. We can also assess the urine's odor, but it is rarely done in clinical setting. But if it's offensive, then it suggests of infection, and if it's sweet, it suggests of glycosuria. Okay, so the procedure itself is very easy. First, we have to check the expiry date of the urinalysis dipstick at the bottle, and then you remove the testing strip. But you have to avoid touching the region squares to not contaminate it. And then you insert the testing strip into the urine sample of the patient, and you have to make sure that all the region squares are fully immersed in the urine. And then once you insert, you remove the test strip, and you have to remember to tap off any residual urine at the edge of the container, and then you hold it horizontally to avoid cross contamination of the region squares. And then you interpret the results by using the urinalysis guide that is provided at the side of the container. And you have to remember that different region squares, they have their own time interval for interpretation. So for example, protein, you have to interpret it within 60 seconds. And then you discard the strip into the waste bin and wash your hands. Okay, so for the interpretation of results, we have a few of like the substance that we want to see if it's present in the urine. So first of all is the glucose, and if it's in the urine, it's called glycosuria, and we have to interpret it within 30 seconds, and it can be caused by diabetes mellitus, renal tubular disease, and some diabetic medications. Second is bilirubin. So you have to interpret it within 30 seconds, and if the bilirubin is absent in the urine, it is normal. So if we have levels of bilirubin in the urine, it can be suggest that the patient might have biliary obstruction, for example pancreatic cancer. For ketones, it is the breakdown product of fatty acid metabolism. You have to interpret it within 40 seconds. And if we have ketones in the urine, it may be caused by starvation and diabetic ketoacidosis. Specific gravity, this indicates the amount of solutes dissolved in the urine. And the normal range is 1.002 to 1.035 milliosmol per kilogram. And the time for interpretation is 45 seconds. So if you have low specific gravity, this is in the condition that results in production of dilute urine, such as in diabetes insipidus and acute tubular necrosis. If it's high specific gravity, then the patient might be dehydrated, or the patient has diabetes mellitus and nephrotic syndrome because of high solute in the urine. Okay, for pH, this represents the acidity of urine, and normally the urine is between 4.5 to 8. You have to interpret it within 60 seconds. So if you have low pH, meaning the urine is acidic, the patient might be starvation, diabetic ketoacidosis, or conditions that cause metabolic acidosis. Whereas if it's high pH, meaning the urine is less acidic, the patient might have urinary tract infection or conditions causing metabolic alkalosis, such as vomiting, and some medications can also cause high pH, such as diuretics. For blood, this indicates the amount of red blood cells, hemoglobin, and myoglobin in the urine itself, and you interpret it within 60 seconds. So if there is blood in the urine, it indicates urinary tract infection, renal stones, any injury to the urinary tract, myoglobinuria, nephrotic syndrome, and malignancy of the urinary tract itself. So for the protein, it will indicate the level of protein present in the urine, and it's called proteinuria. And you have to interpret it within 60 seconds. And the most common cause is the nephrotic syndrome, and as well as chronic kidney disease. For nitrites, now nitrites is actually the breakdown product of gram-negative organisms such as E. coli. So that is self-explanatory. If you have nitrites in your urine, then you might have infection, and you have to interpret it within 60 seconds. So for the last two interpretation, we have urobilinogen. So this is actually the byproduct of bilirubin breakdown in the intestine, and it is normally excreted in the urine. The normal range is 0.2 to 1.0 milligram per deciliter. Interpretation time is within 60 seconds, but if you have high urobilinogen, it might be because of hemolysis, such as in hemolytic anemia or malaria. But if you have low, then your biliary may be obstructed. Okay, so the last one is leukocyte esterase. This is an enzyme that is produced by the neutrophils, and if it's positive in the urine, then it shows that there are presence of white cells in the urine. But if negative, then it is normal. So you have to interpret it within 2 minutes. So what can cause positive leukocyte esterase is, of course, any infection, and then any condition that could result in hematuria. So it's very simple, and that is it from me. Thank you.
Okay, thank you. This is a simple, right? This is a bedside test. Sometimes we miss urine FME because sometimes when patient coming with sepsis, you have to really hard to find the source of infection. So we have to do the urine FME to look for evidence of infection like nitrite, glucoside, and then in other condition in patient in uncontrolled diabetes, don't forget your urine FME to look for your ketone, like apart from serum ketone. And then proteinuria also we have you can do urea FME to look for your protein, and then we can quantify further using 24-hour urine protein. How many topic we have? Oxygen delivery. What else?
Peritoneal fluid analysis,
Analysis. Two more.
and then CBD.
And then CBD. Can we go simple one lah? So tomorrow we should which one is the simplest one? CBD, I think.
CBD.
Right. And then tomorrow we can continue with oxygen delivery and pleural fluid interpretation.
Okay, Doctor.
If you have to continue to complete all the topic today, it's okay. I have nothing until lunch lah. Okay, for CBD insertion, usually in ward, usually we keep until 2 weeks and then we have to change because of risk of infection. Essentially, this is a more on procedure. You have to try yourself lah how to insert CBD. In medical, you can ask from staff nurse in ward. Because you have to try yourself and then you get how to insert the CBD. What is it? It's just use normal saline instead of sterile water. Yeah, that's why we cannot use normal saline. Yeah, please do remember. Any specific question to regards to our CBD insertion? Okay. You want to continue the presentation or we just continue tomorrow? It's up to you.
Continue tomorrow, doctor.
Tomorrow, okay? Any other question? If no question, we can continue our session tomorrow at 11 as well. Anything you can, any query, you also can text me. Okay? Okay, bye-bye. Thank you. Assalamualaikum.
Thank you, doctor.
Thank you, doctor.
Waalaikumsalam. Thank you, doctor.